So hello there and welcome. My name is Tyler Best and I am one of the Springboard community managers. Today's webinar, Generating Demand, Ways to Build Acceptance for COVID-19 Vaccines, is presented by Springboard, an online community under the Breakthrough Action Project. Breakthrough Action is USAID's flagship program on social and behavior change. Breakthrough Action ignites collective action and encourages people to adopt healthier behaviors by forging, testing, and scaling up new and hybrid approaches to SBC. Springboard is an online community of nearly 4,000 SBC professionals from over 100 countries. Springboard can help you advance your SBC skills, connect with colleagues and SBC leaders, and get inspired through resources, events, and jobs. If you're not yet a member already, join today. Now for some quick housekeeping. We will be starting today's event with 3 presentations, followed by time for questions and answers at the end. Feel free to use the chat feature on the bottom to introduce yourself and your organization. Additionally, you may use this feature to ask any questions for the speakers throughout the event. Now on to the show. Our first speaker is Dr. Rupali Limaye, and she comes to us from Johns Hopkins University, where she is the Director of Behavioral and Implementation Science at the International Vaccine Access Center. Over to you, Dr. Limaye.
There we go. No, thank you so much, Tyler. And thank you. It's great to be here. Thanks for joining, everyone. This is such an important topic, particularly because of the news that has been happening this week with the Johnson & Johnson product. And so I'm really glad to be here. And as Tyler mentioned, thank you, Tyler, for the warm welcome. My name is Rupali Limaye. I'm in the Department of International Health, as well as Epidemiology and Health Behavior and Society at the Johns Hopkins Bloomberg School of Public Health. And then I also serve as the director of our Behavioral and Implementation Science team at our International Vaccine Access Center, also at the school. So I'm going to give a very brief overview of what we're talking about with regards to vaccine hesitancy. Thank you. So we're going to start in terms of where we are with current vaccine products, especially here, I think, focused on what has been approved. We'll talk a little bit about drivers of vaccine hesitancy in the COVID-19 context that's also specific to marginalized populations. And then I'll talk very, very briefly and give some broad thoughts on how we should communicate about COVID-19 vaccines. And so if we can go to the next slide. Great. So as of April 2021 of this month, we now have really 3 products here in the United States. So we have 2 mRNA products and we have a Johnson & Johnson product, which has been put on hold. There's also, I should say, more globally speaking, there's the AstraZeneca product and there's also the Chinese product as well as the Russian product. But here in the United States, we have 3 products that have gone through the emergency use authorization concept, meaning that individuals do have a number of options so far with regards to a COVID vaccine. If we can go to the next slide. Looks like there might be something with the presentation. Yeah.
Sorry about that. Some technical difficulty.
No worries, no worries.
Give us 1 second.
Thank you. Thank you, Tyler. Yes, this is the correct slide. So what are we dealing with now from a communication perspective? And so when a COVID-19 vaccine becomes available, which we are now finally at that point, luckily, and we have a number of products that are available for use, is that it's really important to try to determine how can we assure the public that vaccine recommendations really reflect the state of knowledge and are evidence-based. And one of the issues that we're facing with now is that this problem of how to communicate about the recommendations regarding vaccines is that we are in a time of crisis. We've been in a pandemic for more than a year now. I think people are tired, and there's a lot of scientific uncertainty. And what I mean by that is that because this is a dynamic situation, things are changing rapidly. We're asking people to do things, and then as we gather data and we're able to update scientific recommendations, we ask people to do different types of behaviors, and that has been a real challenge. The other piece that we have seen that has been a struggle with regards to communicating about the COVID vaccine is that other available measures have had a limited effect. And what I mean by that is that all of the non-pharmaceutical interventions that we're asking individuals to engage with, so that's wearing a mask, social distancing, staying at home, what we have heard is that people will say, yes, I can engage in these behaviors, but people are still dying. And so people see them as maybe not as effective. So it's been a real concern. The other issue that we've really been faced with regards to hesitancy is that with regards to this pandemic and over the last year, the voice and the face of what we should be doing with regards to behavior change has really come a lot from politicians rather than experts. And that's been a real challenge with regards to trust, which I'll talk about in just a minute. So if we can go to the next slide. Great. This is a graph that's essentially looking at us, and this is specifically in the US, and I'll talk a little bit more about global issues, but a number of individuals and groups have been tracking vaccine hesitancy over time, essentially asking individuals their intention to get a vaccine once it becomes available. So what you can see here is that in March of last year of 2020, when we started this pandemic, we saw that about 65% of the population generally would be willing to get a vaccine once it's available. So if you look across and start going from March all the way until about the end of the year, we see that that has declined. And if we continue to look at this graph, we can also see that the confidence in the COVID-19 vaccine products has actually decreased further. We saw an increase in confidence once the vaccine started being rolled out, but we're still struggling with pockets of hesitancy, which I'm going to get to. If we could go to the next slide. A key piece, sorry, this is a little bit small, but a key piece of the hesitancy work is one thing that we do know, not only just because of COVID-19 vaccine hesitancy, but previous issues with regards to vaccine hesitancy, is that these types of attitudes where people are concerned about a vaccine very much cluster. And what I mean by that is that individuals hang out with like-minded individuals that might not be willing to accept a vaccine. So if we think about that and we think about this by demographic group, we know that there are disparities. So for example, we know, for example, this essentially says percentage of respondents who expressed hesitancy by group. You can see, for example, rural residents here, this is taken in the United States, but that rural residents are much more likely to be hesitant compared to urban residents. The other piece where we're seeing a distinct difference with disparities is from political ideology lines. So those that are more conservative are less likely, as well as those of communities of color. So Black adults and Hispanic adults are going to express hesitancy much more than white adults. If we can go to the next slide. So the question is, what has been driving hesitancy within this context? So if we go to the next slide, I want to talk a little bit about pre-COVID, what we were dealing with. I've been studying hesitancy for about 6 or 7 years now. And before the pandemic started, we essentially heard 4 arguments related to hesitancy. One was related to vaccine ingredients. Individuals would tell us that they were concerned what was being put into vaccines. The second argument that came up was related to the vaccine schedule, meaning how many doses an individual would have to receive to have a complete dose over time. The third was this misperception of this link between vaccines and severe adverse events. It has been soundly refuted in more than, I think, 600 studies now that there is no link between vaccines and autism. However, this misperception still persists and is a driver of hesitancy. And finally, low levels of risk perception, that individuals would tell us, why is it important for me to get a measles rubella shot? I've never seen measles in my life. I don't think it's severe, and I don't think I'm susceptible. So pre-COVID, these were really the 4 main arguments that we would hear. So how has that shifted? If we go to the next slide, we can see that within the COVID context, it's really shifted from, I think, specific vaccine-specific factors to more broader health systems or structural level factors. And what I mean by that is that we are definitely seeing issues related to distrust and lack of confidence. So this is distrust not only in public health, but distrust in governments in general. And of course, a decline in trust towards healthcare providers, which had been going before COVID-19 pandemic hit. The other issue that we're really struggling with regards to hesitancy is misinformation, and I'm sure many of you could speak on this. Thinking about misinformation that generally has been fueled by social media platforms has been a real issue and a real concern with vaccine confidence during this pandemic. The other piece that we're seeing, the third piece, is related to polarization of attitudes. I think 10 years ago, if you had a conversation with an individual that might be vaccine hesitant, you could at least have a civil conversation. These discussions have become very, very politicized. They've become very heated. And we're seeing that there is less agreement in general, which causes real issues when we're talking about interpersonal communication. We can go to the next slide. Great. So if I can break each of these three topics down, let me start with distrust and lack of confidence. And I've put this up here because I work primarily in the last year, I've been working with especially individuals that are Black or Hispanic with regards to their issues with hesitancy. So there has been a real change as this pandemic has unfolded. And we've also seen this in other countries with regards to marginalized populations, that these types of populations have really changed the ways in which they're looking at the vaccine. Whether or not they feel comfortable, what has changed, a lot of it has to do with how they trust their government and how the government has really handled the COVID-19 response in their specific country. So if we go to the next slide, I can give you a little bit more context of this. So for example, some of the work that I've been working on is working with African Methodist Episcopalian Zion congregations. And this has changed now because this has gone up to about 25 congregations over the last several months, where there are some key concerns that come out. So these are individuals that are African Americans. They're primarily over the age of 55. And these are the key concerns that we continue to see. So one, that there's distrust of the vaccine development process. People are concerned at how quickly the clinical trials were developed, whether or not the recruitment of participants was representative, and whether or not they really felt comfortable with the way that the clinical trial regulatory process was handled. In addition, as I mentioned before, the other thing that has come up is distrust of the healthcare system. This is not only because of a history of medical experimentation, but also current interactions with the healthcare system with regards to not feeling listened to, not feeling trustful of the healthcare system, and feeling as though individuals that are marginalized, their concerns are not heard in the same way compared to, let's say, white populations. In addition, there has been issues related to lack of confidence. The specific questions that I have been getting is that, is the vaccine safe for Black people? How can you tell me if it's safe for me? And that there's also a lack of confidence related to the safety of vaccine and other comorbidities. I think many of you know, especially that are working in other settings, we're dealing with a lot of individuals that are on other medications. People are concerned about taking the vaccine, whether or not there could be an interaction between the medications that they are on and the vaccine itself. So if we go to the next slide, similarly with regards to these churches, I've also been speaking to incarcerated populations, so individuals that are residing in prisons here in the United States. And again, this has gone up a little bit more. I've met with about 6 different prison groups. And one of the things that we're hearing here, this is among us, a younger subset of this population, but very similar concerns. So still distrust towards the vaccine development process, still distrust of the healthcare system. But the additional concern that we have been hearing is also concerns about the efficacy of the vaccine itself. This is played out nationally as well as globally. As many of you know, the mRNA products are being really compared to the vector products, and it's not really a comparison that we can make simply because it's apples to oranges, that those clinical trials had different endpoints. And so it's a real challenge for getting people to understand that the product itself is efficacious, and that's a reason why you should be able to accept it. Go to the next slide. Great. Misinformation and disinformation, as I mentioned before, this has been primarily fueled by social media. And while social media has been great, as a number of us have been locked down and unable to get out and about, we're really relying on social media more and more for all information, including vaccine information. But one issue that we're finding is this idea, and in 2018, dictionary.com, the word of the year was misinformation. Essentially, when people spread misinformation, they believe what they're sharing. And then there's a distinction between misinformation and disinformation, whereas disinformation is crafted and disseminated with the intent to mislead others. And so an example I can give you is that if a political leader says that COVID-19 is no worse than the flu, despite knowing that that is not true, that's disinformation. But then when an individual hears this, believes it, and then shares it on a social media platform or interpersonally, that is misinformation. So if we go to the next slide, we have seen this play out in a number of different ways. One thing that we are seeing, and this snapshot that you're seeing here, is essentially links between vaccine-related Facebook clusters, and the connections between those red dots. Those are individuals that represent anti-vaccine attitudes. You then have the blue dots, which represent pro-vaccine attitudes, and then you have the green dots, which are really undecided. One of the things that we're seeing here is this polarization of attitudes. Before, we would have a lot more mixing of individuals that felt like they might be undecided, but we're starting to see much more disparate, I would say, and breaking off of groups, that there's less discussion between these two types of groups. Why is that a problem? That means that individuals that are anti-vaccine are only being exposed to information from other individuals that are anti-vaccine, and that causes something called an echo chamber, which I believe is the next slide. And that's the concern that we're really dealing with now with regards to misinformation. Essentially, when people are looking for information on vaccines on social media, they tend to only see information that already agrees with their pre-believed notions and beliefs. Again, issue with that is that no innovation is allowed to occur, meaning these individuals are not going to hear information that is different than what they believe. And this is a real issue with regards to misinformation. If we go to the next slide. So the question is, I'm going to end on just a couple of slides, and I'm not going to get into detail on this, but how should we communicate, right? If the issues that we're dealing with are really related to distrust of the healthcare system, if there are issues related to vaccine confidence, if there are issues because of misinformation and polarization, what are some universal ways that we could communicate about vaccines? If we go to the next slide. So there's some key points here, I think, that are very critical with regards to this vaccine rollout process. So trust is a big one. And as I mentioned before, a lot of individuals that we have spoken with, not only here in the United States, but in a number of the countries that I work in, do not trust the government. So they don't trust when the government is rolling out a vaccination program, for example. And so it's really important to communicate, to build, maintain, and restore trust. So one example I can give you is communication regarding side effects. I'm sure many of you have heard the news earlier this week that the J&J vaccine has been put on pause. Again, from a vaccine confidence perspective, this is the right thing to do, but it's really important moving forward that individuals and regulatory bodies that are looking at the data are very clear and are communicating the side effects, including probabilities and risks, in a way that individuals understand them. So trust is number one. The second thing I would say is announcing early. One thing that we have heard, we did a review of communication activities across the globe to see which countries did it right when the COVID pandemic started unfolding. And one thing that we saw was that individuals that really, governments, I would say, and leaders that use proactive communication, it was really crucial. So even if individuals came and said, listen, this is what we do know that's happening, this is what we don't know, and had frequent communication, were rated much more highly compared to countries that did not do this. So an example I can give you is we have been working very closely with our mayor of Baltimore, Maryland, on his press briefings in his office. And one thing that we have really been focusing on is making clear that when there is a press briefing, when there's any sort of communication, that it's frequent and that it's very transparent with regards to what do we know about the vaccine, what do we know about rollout, what do we know about allocation, for example. This goes hand in hand with our third example, which is transparency. So one thing that we have seen and how this has played out within COVID is the dissemination of trial data. I think previous to this pandemic, most people, I think the general public, did not have a good understanding of how the clinical trial process unfolds. I think because the trial data has been so transparent, that individuals have been transparent with the Johnson & Johnson pause. This really helps build transparency that this is a system that is built on safety to improve confidence in a vaccine product. Finally, the fourth issue, I think this is one of the most important issues that people really don't think about and incorporate in their program systematically, is listening. One thing that I have learned over this last year is that individuals have been living in a very uncertain time. They have questions, they're concerned, they're fearful, there's anxiety. And so taking the time and thinking about how we can better understand risk perception, people's views and concerns, is really critical to effective communication. And this should be done at all levels. If we go to the next slide. And I think this is my second to the last slide. Yeah. The other issue with regards to trust, again, the main issue that we're dealing with here as to why people are concerned and have concerns with the vaccine, is we have done some work where we have looked at different systematic processes as to how to improve trust. And this is in a book that's here on the right. But one thing that we have learned is that it's very important from a communication perspective to not correct misperceptions. I think our gut and our default response is that when individuals say something that is not true about, let's say, the COVID-19 vaccine, is that we automatically want to reject that and miscorrect them. we have found, and others beyond us have found this in randomized controlled trials as well, is that this is not the right approach because this can lead to something called backfiring. So instead, what individuals should do is focus on the disease. So if someone comes to you and has a misperception or a misconception or misinformation about the vaccine, the important thing is to automatically pivot that conversation to the disease itself. Talk about severity of COVID, talk about how all individuals are susceptible to COVID. And so pivoting the conversation is a key technique that we've been using. The other important piece with regards to an approach is something called presumptive communication through nudges and defaults. I'm sure many of you are familiar with this, but I think some people are surprised to know that vaccination is the norm. The majority of people vaccinate even before COVID. And so it's important to instill that and really utilize and leverage social norms to allow people to understand that people will get vaccinated and to really structure conversations in this presumptive way. And then the last step, as I mentioned on my last slide as well, is really having empathy. Again, as I mentioned, individuals are anxious and they're scared. And so just taking a minute and understanding where people are coming from, why they might have concerns, is really critical to help increase trust. And I believe that might be my last slide. Yes, thank you so much. It was great to be here. I hope I get to interact with you over the next 40 minutes or so. So thank you, Tyler.
Thank you, Rupali. Okay, great. So thank you, Rupali. Our second speaker is Miss Deepa Pokharel. Deepa is a communication for development specialist at the UNICEF Health Section, where she currently sits in the New York headquarters. I will unmute you and then over to you, Deepa.
Thank you so much, Tyler, for that introduction. So just in a summary, my name is Deepa Pokharel, and I am the Communication for Development Specialist working in Health Section, as Tyler just said, in New York. But I come with more than 20 years of experience in SVCC, in UNICEF country offices, the regional offices, as well as my own home country, Nepal. So quite a lot of field experience as well. So today what I would be presenting is focused more on what is going on at the global level in terms of the tools, guidance, the thinking, and then some of the data. And it's a really nice segue after Dr. Rupali's presentation, because some of the things that I would be talking about really complements what she's already started with the database and the vaccine hesitancy and so on. Next slide, please. So the flow of the presentation will be basically, I'll talk a little bit about the global context, some examples of what we are seeing from our country level data. I'll also share with you some of the global resources which have been developed and some examples of how we are rolling out the tools and guidelines and possible roles that partners can play to make sure that the vaccine rollout is supported. Next slide, please. I wanted to start with this slide. When the COVID vaccine was being manufactured, then at the global level, a number of partners were getting together to make sure that when the vaccine becomes available and is ready to be rolled out, there are enough tools and guidelines to support the countries to make sure that they have the tools necessary to roll out the work in the country level. And different work streams were established under the country readiness and delivery work stream, which is a global coordination mechanism. But then there was different work streams which were working on it. Some working on communication advocacy training, others on data monitoring, supply, and there was an overall coordination mechanism. But in the implementation part, one of the subgroup was the demand group. And the work that I'm actually going to share today is on behalf of the demand group. And you'll see all these partners, WHO, UNICEF, Gavi, Bill and Melinda Gates, CDC, IFRC, and also UNICEF headquarters, as well as regional offices are represented there. UNICEF chairs the demand group together with Gavi. Next slide, please. So you have already heard it from Dr. Rupali, so I don't think I need to go into detail of that, but just in a snapshot, what we are seeing, which also actually complements what Dr. Rupali has already shared, is why is it that the COVID-19 vaccine is a bit different in terms of communication? We've done tons of, not tons, but many vaccine introduction all over the world. And more or less the vaccine introduction strategies and plans would be very common. But this time what we've seen in COVID-19 vaccine, which makes a little bit of a difference and a challenge, if you like, for communicators, is that vaccine hesitancy is very high among some, but then it's interestingly there are others who really have high expectation that the vaccine will be available very soon. So we are actually almost at a double-edged sword where we are trying to address the vaccine hesitancy, but at the same time we have to make sure that we communicate well about why certain people are not getting the vaccines. Another thing, as Rupali also said, is the vaccine hesitancy is really high, more than ever, among health workers, because health workers in this case are not just the vaccinators. They are also the recipient of communication. So what are the things that they would need? Or what are the communication messages that should go out to them to build their confidence in vaccine? Because if they are not convinced, then it becomes very challenging for them to convince others. The other thing which is also quite different is that I think globally partners know very well how the under 5 vaccination works, and we've got really a solid experience in this area of work. But adult vaccination is something that we are still learning. Of course, the HPV and TT and flu vaccines were there, but not to the extent that we knew about how it works for the under 5 children. So the range is very big, and then everybody is eligible for the COVID vaccine in the long run, if you like, but while the evidence is still being gathered. And then the other thing which is also quite unique in this case, and I think Rupali also alluded to this, is that the vaccine is there, of course, it's being rolled out, but it's very important to look at this as vaccine is one of the things among many other things that we need to do to protect our people and ourselves and our families and loved ones. So the promotion of uptake together with the vaccine uptake becomes really, really important. There are equity concerns. I don't have to say that most of the rich countries have exceptionally high percentage of vaccines compared to the global South, Africa, and South Asia, basically. Infodemic, I'm not going to talk more about it. I think it's been covered well. There is supply constraint. There is a COVAX facility at the global level where partners have come together and have tried to make sure that at least some percentage of vaccine to protect the frontline workers, the health workers, are there. Up to 3% to 20% of the vaccine are being given to countries through the COVAX facility, but that's not going to be enough. Mistrust is there. Multiple vaccine makes people confused about, whether this vaccine is good enough or should we go for that, and why this vaccine and not that. There's lots of uncertainties and unknowns because we are getting new information every day, swiftly changing context, and then the side effects. I think Rupali already covered that. Next one. There is a group called, and many of you in the call I know would know it, the Strategic Advisory Committee, which is WHO led. WHO has a strategic advisory group of experts who decide on, who make decisions, who recommend what would be the best thing to do for immunization globally, not just for COVID, it is for all the vaccine rollout. So in terms of who should be getting the vaccines first when the vaccine supply is a constraint, the recommendation has been health workers, older adults, people with pre-existing condition, and then the essential workers as vaccines become available. But we as communicators, we need to know why these people, because people are going to ask us questions. So why health workers is very obvious, because they are in the front line, they come in contact with the COVID patients more than anybody else, so they need to be protected. So obvious reason, and data is showing that health workers have really been affected in the days when COVID outbreak started. Older adults, also coming from the data, it shows clearly that the mortality has been high among older adults, but the cutoff age is decided by the countries, of course. People with pre-existing condition like high blood pressure, diabetes, cancer, and these kinds of things. But it's very important to note that while these recommendations have been put forward by the SAGE, this is an advocacy agenda that we need, whoever works at the country level, we need to make sure that we advocate that these people, at least the priority people, are not missed out. But at the same time, it's also important to note that the government makes the final decision based on the SAGE recommendation. So you would see that, in many countries, it's going to be very different when it in terms of who is eligible for getting vaccine. Like in the case of US, for instance, now everybody is getting it above 16, 18 years of age, whereas in other countries, they've decided for anybody above 45, others would be deciding 65. So I think the message here is that the government is in the driving seat and they are the decision makers. Our role as partners partners is to make sure that these SAGE recommendations are not forgotten, and we communicate to the public that these are the reasons why these people are being prioritized. Next slide. So I just want to dwell a little bit on data. I think at the global level and particularly on the US, Rupali covered that quite well. I just want to make sure that you also get a flavor of what we are seeing overall from all over the different countries. Next one, please. So these are samples. These are not exhaustive. I've just pulled a few slides so that we'll be able to see. So Nepal has been doing quite a lot of data collection, and Nepal is one country which has always enjoyed high percentage of coverage of immunization, the routine immunization. But when this data was done, you would see that 91% are willing to take the COVID-19 vaccine if it's available, which is very high. So respondents from upper income groups and those from provinces who are more accessible, they have shown that the vaccine interest is higher. There is fear of side effects and lack of trust. So I think the one thing which had come out in the initial days for Nepal is that the vaccine hesitancy among health workers was high, and there were reasons for it because people felt that this was a trial which is being done in developing countries, and there was a message from which was going out that this is being tried in a few countries in Asia and so on. So, but when the WHO emergency approval came, I think the hesitancy really decreased quite a bit. So I think we just need to look at what the social data is telling us together with the coverage and the case data, the surveillance data, and then combine it to see what are the actions that we could take. So I think there was really a lot of efforts to make sure that the health worker hesitancy actually reduced with the actions that we took. And then one of the things they had said is we'll only get vaccinated if the politicians, the influencers are getting vaccinated, because the trust issue is there. So, there's been a drive also to make sure that the politicians are being seen vaccinated. Next one, please. This is a slide from Pakistan. So there has been, of course, like in any other countries that we've been supporting as UNICEF and other partners in country, is that there has been quite a lot of interventions going on for communication. So from January to February, you will see that 128 million people were reached with message, but it does not necessarily translate into increase in acceptance. So that's what this slide is telling us. So it's more or less plateaued at 65-66% of people wanting to accept the vaccination. Then the country team started thinking about what more is there, what could we do, and what is the reason for vaccine hesitancy? Is it a trust issue? Is it a side effects issue? And then one thing which also came out was that 62% of the people in Pakistan, they said that they would believe the religious leaders. And the insight is that people's trusted source of information strongly determines their attitude towards the COVID-19 vaccine. So if the religious leaders are the people who are really trusted, then the action point, the recommendation was that the engagement, it's not just actually just giving out them the messages, but really taking them as partners and engaging with them to see how can we reach the constituency that they believe in, because there are so many people who believe what the religious leaders are saying. Next one. Again, this is a very interesting slide. So we have been doing different kinds of data collection in Pakistan, from community rapid assessments to social media sentiment analysis, qualitative surveys, and so on. So the reported survey was showing that even if it's not as high as in Nepal, it has been more or less, it's gone down a bit, but then it was still around 80, sometimes 80%. It has gone down now to less than 80%, was saying that the behaviors were being followed, basically hand washing, mask, and social distancing, you would see. So the country team wanted to see whether what is actually happening on the ground. So an observational study was decided because the cases were still quite high. And then when the observation study was done among 7,000 people nationwide, they saw that 88% do not wear masks at all. So you'll see that the reported cases is quite high, but in reality, actually, the mask wearing was in practice was not high, and 9% were not wearing masks appropriately. So it means that just because the information is going on, the reported data is coming out as positive, we need to look at the holistic picture. So different tools would help us to look at the trend analysis. Another interesting thing was that the people in Pakistan, whether it's not just men to men, also the practice is that the females would also be shaking hands with females. So this practice has actually really been avoided since the COVID started. So that was quite a positive thing. So, after the qualitative insights of all these things, the fear of social disapproval, affordability, the low risk perception, and all that, the action taken was to reinforce the dangers of COVID-19. It's real. And the country team has actually shown people with COVID going on air in TV and radio talking about how risky it can be for people. Next slide. And this is from Africa, just some qualitative study, because the Africa team, together with 4 partners, UNICEF, WHO, IFRC, and a few other partners, have been looking at this regularly to get community feedback on what they feel about vaccines. So I'll just read out 1 or 2 of them, and you can read the slides later. We want to see our leaders take the vaccine first to prove they are safe. You see, it substantiates very much with what Nepal data was showing as well. And then the other one is why are some vaccines labeled not for sale in USA, UK, Australia? So there's suspicion in that. If not safe for them, why should Africa accept it? The vaccine will be used to control people using a registry. It is going to affect us, the fact that there is no such disease. So all kinds of things are coming from the community perception. And what happens later is that once you look at the whole data and triangulate it, there's a recommendation from the team. Normally, this is led by a social scientist. So one of the recommendation was that the country team should ensure they have appropriate rumor tracking mechanisms. And I'm happy to say that the social listening system has really establishing the social listening system, but also looking at the data holistically and using it to inform the program has really been strengthened since the COVID started. Next one, please. So I'll go into some of the operational part of what can be done. And these are basically at the country level we are thinking of. So what could be some of the key consideration when we are developing a demand generation plan at the country level? Government should be in the driving seat. So the coordination becomes really, really important, more than ever in the COVID-19 vaccine, because there are so many uncertainties. If people start going and speaking about their own way of looking at things, then it does create a lot of confusion among the people, the communities that we are trying to serve. So government-led coordination mechanism, but all partners to come together and speak the same language to support the government. Establishing a social listening ecosystem, as I said, tracking both. When we say social listening, we are not talking just about the social media. It has to be actually looked at holistically, looking at the online, offline media, community conversations going on through smaller closed WhatsApp group. What are the mainstream media like newspapers and television and all, saying the helpline data. So this is something that we'll have to look at it on supporting all these data collection tools. And then the social data collection and use to look at more of the behavioral part and what is it that we are seeing. But it has to be also, I have to actually also make a point that this has to be done in a very rapid turnaround. We can't wait for 6 months to 8 months for a regular cap. So that's why we are moving more towards the rapid surveys these days. Evidence-based planning, looking at the data, having a crisis communication plan, absolutely important, because we've seen this coming up again and again. Every day there's a new information, and communication people need to be ready on how we are going to mobilize the whole system to respond to it. And then identifying the vulnerable and marginalized groups. Next one. And then again, continuing, keeping communities at the heart of everything we do is going to be so important. It's not just mass media. Mass media can create an enabling environment. Social media campaigns can reach out to certain groups of people, but face-to-face communication, giving information through the trusted and credible source of information becomes really, really important. So we will have to look at what are the available communication channels to reach these different populations we are trying to reach, and then engage with them accordingly. But at the end, it's going to make a lot of difference when it's a face-to-face communication combined with other sources of media. And then promoting the vaccine as one of the interventions to protect the population. Vaccine is not just a magic bullet. We don't have enough evidence still on efficacy and how long it's going to protect. And while the data is still being collected, the science is going to drive the communication efforts. It's also important to say that we need to continue with the other interventions. And let's identify the influencers who can actually be very influential in communicating to their people. Vaccine hesitancy, and then leveraging the resources. Let's look at the overall costed national plan and see which partner has the comparative advantage to do certain things. Like, for example, the Red Cross is excellent in reaching out to the communities. Whereas my experience of working with JHUCCP in country offices has shown that the data collection and then looking at the high quality, top quality communication material, the Breakthrough Action Project have done just a lot of wonderful work, and we can leverage on the past lessons learned to make sure that we do the same thing for the COVID. Next. Just continuing with the advocacy with the stakeholder engagement is also another important element of the work we need to look at. And then whatever we have planned, to work together to implement it. Building capacity is something I would really want to highlight, particularly of the health workers, because they are such an instrumental stakeholders in this whole rollout of the COVID-19 vaccine, but also of the communities and other stakeholders. And then finally, I think as communication people, we are good in communicating to people. We've come a long way in using data for informing our strategy, but we are not yet there when it comes to monitoring and reporting and the effectiveness of communication. Not an easy thing, but we'll have to work on that. And one of the things is the government, usually government's data does not pick up the communication indicators. So we'll have to do a specific, measurement tools. We'll have to use either surveys, the rapid assessments and all to find out what has been the effectiveness of communication. Next one. So just a few slides on the tool. So this was developed by the global tool working on the demand generation. There are altogether 11 tools which has been developed from which would guide the planning, the behavioral and social data for action. There are training modules which is available together with the job aids. There is a community engagement guide, the social listening and digital engagement field guide has been produced in different languages. It has been shared through the partners who are part of the demand generation work, but also this is an opportunity for you guys to actually have access to it. There are tools which are easily adaptable. You can look at it, you can contextualize, you can translate it and see how best you can use it. And this is very much linked to the vaccine introduction readiness and assessment tool, which usually WHO sends it to the country office to do an assessment whether they are ready or not. And last thing, there is also a safety manual which has been produced by WHO and partners, and chapter 9 is specific to safety communication. You can also have a look at that, which would help you to guide some of the misinformation, disinformation discussion that we've been talking about. Next. So these are just links. You can look at it. Next one. Just some visuals of it. I think I'm almost towards the end. I see that there was 1 minute remaining. Yeah, next slide. So this is again the 10 steps to community readiness. You can have a look at it. It's a very simple thing that anybody can look at it and contextualize. Next. I just wanted to share that this is the way that the rollout of the material has been happening. So the national vaccine deployment plans does include a component on SPCC, which is basically in the immunization world, it's called demand generation part. Under the leadership of government, the plans have been developed, and then the capacity building is going on at the federal level, at the subnational level as well. It's been disseminated widely through UNICEF, WHO, IFRC, and other partners. WHO open site already includes the training modules, as well as the NDVP trainings. Regions are conducting interactive webinars on a weekly basis on thematic areas. These tools have also been digitized, and these are being used through Internet of Good Things, which is a website that UNICEF has been supporting, and other languages as well, on training content as well as for the surveys. Next one. So these are some of the possible roles we see as partners who would be able to support. Let's get together at the national level, support the Ministry of Health to do the planning, to identify priority population on data, most importantly, to make sure that the communities who should be prioritized are engaged and working with influencers and so on. So I'll stop there. I think that's the last one, Tyler, if I remember correctly. Yeah, and this is the Vaccination Demand Hub, which is a global coordination mechanism where all the partners come together and look at the tools and develop the tools. And this has been really a phenomenal experience working with different partners to produce the same tools, which goes out to the country offices as one window. Thank you so much.
Thank you, Deepa. That was great. Our third and final speaker today is Dr. Samuel Usman. He comes to us from Core Group Partners Project Nigeria program, where he is the Secretariat Director and Chief of Party. Over to you, Sam.
Good day, colleagues. It is indeed my pleasure and privilege to be sharing with you the experiences that Core Group Partners Project has garnered over the years of working in the immunization space. CGPP is Core Group Partners Project or Core Group Polio Project. So we are called Core Group Partners Project or Polio Project, depending on the location. Next slide, please. This is primarily what we do. So I'll be sharing with you our experience in ensuring that every child that is eligible gets the oral polio vaccine into his or her mouth to protect them from paralysis due to poliomyelitis. So during this presentation, I will be sharing with you some of the lessons we've learned over the years in working in polio and how those lessons on the field can be used to improve acceptance for the COVID-19 vaccine. The difference, of course, is that like my previous speakers have highlighted, this vaccine is for a wider age group, that is not for under 5, like the other polio vaccine, but for adults and elderly people. Next slide, please. Now, in Core Group Partners Project Nigeria program, we began to support the polio eradication initiative in Nigeria since 2014. But I must say that in other countries, CGPP has been existing in places like Kenya, Somalia, in places like South Sudan, places like Ethiopia, places like India, as well as Uganda. And in all of these places where we work, our strength is that we work through civil society. And the reason why we work through civil society is because civil society are the closest people that are in touch with the communities where we work. And because civil society organizations are closest to the communities, they have a feel, they have a relationship, they have the pulse of the people. And so with funding from United States Agency for International Development, our goal when we started the program was to contribute to polio eradication by increasing population immunity and enhancing surveillance of acute flaccid paralysis. We're working in 8 countries, and we started in 1999. And our major strength is through our work at the community level, working through a cadre of healthcare workers that we call volunteer community mobilizers. We use these mobilizers to raise awareness on the importance of oral polio vaccine. And I can tell you, colleagues, that with funding from USAID, we were able to use these same volunteers to raise awareness on COVID-19, and we've seen remarkable progress in this regard. Next slide, please. Now, what are the things that we do at the community level? We focus on improving the vaccination process, which is the campaign quality. We focus on improving general access to immunization antigens. We also ensure that we have a mechanism in place to detect acute flaccid paralysis or children who have polio, and then we improve social mobilization. You may ask yourself, how do all these relate to the rollout of COVID-19 vaccine? Next slide, please. Now, in all of our work over the years, we've realized that there are certain interventions that are of high yield within the context of the COVID-19 vaccine. And one of those is house to house. During this house to house engagement, of course, our volunteers are expected to abide or adhere to the COVID-19 protocols. That is, they use face masks, they observe physical distancing of minimum of 2 meters, and of course, they also use their hand sanitizers, they wash their hands. And in those house-to-house interactions, they talk to the people to get them to understand that this vaccine is beneficial, this vaccine is useful, this vaccine does not cause infertility, or does not cause, it's not a population reduction strategy, because that is one of the biggest issues we're dealing with in Nigeria. And that is why in Nigeria, one of the biggest things we're dealing with is stigma. Stigma, because if you are found positive of COVID-19, you are said to have a white man's disease. So that's one of the biggest issues we had to deal with. So our volunteers go house to house, they speak the local language, which is a plus. So in ensuring that we are able to address COVID-19 vaccine hesitancy, you need to be able to communicate with those who are hesitant in the language they can understand. So that is the first thing. Our volunteers communicate in the local language. And as they communicate in the local language, they also look at the environment. Like Rupali said during her presentation, you must be able to engage with the hesitant people. And one of the strategies we adopted is the compound meeting. And interestingly, I can tell you that there are healthcare workers in every household. There are healthcare workers in every compound. So in Africa, you know, our buildings are not like in Western world where you have streets well paved, the houses well numbered. In Africa, a lot of times the community is not properly laid out. There are no house numbers, there are no street names. So every compound matters. And we use the same process that the micro planning, we use the same process of micro planning for polio, for COVID-19. Micro planning simply means that you look at the settlement and count each of the houses. And as we did this micro planning, we realized that in houses where there are healthcare workers, we had to engage them during these compound meetings. And in order for us to reach a larger number of people, we engage them using the community dialogue. These are high-yield interventions because you are likely to meet a large number of people. And as you meet with them, you communicate with them in the local language. Another experience we had is that there are high-yield activities that are happening in the locality. One of them is when there's a naming ceremony. In Africa, where I work and where I come from, the birth of a new baby is a thing of joy. And it is widely celebrated by family members and external people. And they call that ceremony Suna in Hausa. And during this Suna vaccination, healthcare workers, non-healthcare workers, all members of the community, they congregate to rejoice with the family that just gave birth to a newborn baby. And what do? We have our volunteers in those locations. They interact with the people. They talk to them about the importance of the COVID-19 vaccine. They talk to them about, they try to address some of the misinformation or disinformation that Rupali talked about. And one of the commonest disinformation is that COVID-19 is a white man's disease. COVID-19 does not affect Blacks. Sunlight kills the virus. And our volunteers begin to engage them. And during those engagements, they try to dispel some of those misinformation and misconceptions that these people have. And perchance that the person they are talking to does not want to have the COVID-19 vaccine or does not want to have the other polio vaccine. What do? They go back the same day. So they say, oh, okay, you don't believe in what I'm saying. Okay, can I come back and see you? That's what we call same day revisit. In the polio program, we realized that visiting the house again that same day tends to reduce the tendency of final refusal. What that means is that if the person is hesitant, you say, okay, can I come back and talk to you? If they say, oh, yes, they say, okay, I'll come back. Now that same day revisit tends to ensure that the engagement, the intensity of the engagement is not lost. And then the last speaker talked a lot about this engagement of religious and traditional leaders. We've realized that one of the major things that drives hesitancy of vaccine refusal is things like culture, tradition, peer pressure, which override every other thing that these healthcare workers or people in the community may have learned. It amazed us that even people with high level of educational attainment were susceptible to the same misinformation or disinformation that other less educated people were susceptible to. But we found out that all of them, the overriding denominator for all of them was the fact that they all listened to their religious traditional leaders. And what we did was that we began to engage the religious and traditional leaders. We looked for the head of those religious and traditional leaders, who is the Sultan in Nigeria. And we engaged him by forming what we call the Northern Traditional Committee on Polio Eradication and Routine Immunization. Using the same platform, we engaged them on the need to talk to their subjects on the importance of COVID-19 vaccine and the importance of the fact that this vaccine is safe. The vaccine is not white man's disease, and of course, the disease is not restricted only to the white man. And you realize that whether you are a healthcare worker, you are a teacher, or you are an illiterate, the unifying factor is that you observe the same religion or observe the same culture with people in that environment. So we realize that engagement of religious and traditional leaders plays a critical role in getting people to yield to acceptance of any kind of vaccine. What else did you also realize? Use of community informants. Community informants are people within the community that the program recruits for them to go around and try to find out if there are cases of acute flaccid paralysis from polio in the community. For COVID-19, what these community informants do is to tell us if there are areas where people have a lot of hesitancy. And what we also did was that these community informants, we have them in areas that are inaccessible. So what the program did was to recruit these informants in areas that have, for instance, insecurity. Like some of you may know, Nigeria has a lot of insecurity from banditry, from kidnapping, and even in the Northeast where we have Boko Haram. So these community informants in inaccessible areas serve as a means of getting information that no one else can get, because they speak the local language, they understand the local challenges, and they're able to communicate with people there. And then the directly observed polio vaccination is, of course, directly observing the process of a child being vaccinated. Now, on the flip side for COVID-19, what we did is to ensure that during the time that people are being vaccinated, the program staff are there, the VCMs are there, and they interact with the people as they are waiting to be vaccinated. What they also do is that they get some of the experiences or some of the fears of the people who have been vaccinated, and from there they're able to get information with which to engage people who are hesitant. And then an important aspect of the messages that our volunteers give at the community level, which they also provide to healthcare workers, is convergent messaging. Convergent messaging simply means that you have one message that carries multiple messages concerning different areas. For instance, convergent messaging can talk about the importance of accepting oral polio vaccine, the importance of accepting the COVID-19 vaccine, the importance of hand washing, the importance of use of face masks, the importance of physical and social distancing, the importance of using your hand sanitizer, the importance of not self-medicating when you have symptoms that you think is COVID. So this convergent messaging has done a great deal to helping us to raise awareness in the communities where we work. And of course, last but not the least is Polio Plus. What does Polio Plus mean? Polio Plus simply means that apart from messaging around polio, this is related to convergent messaging, we also add messages around COVID-19. We also add messages around people that have taken the vaccine and they are safe. For instance, I became an advocate. Well, I've had the AstraZeneca vaccine and I'm okay. I had absolutely no side effects. So our volunteers also go around to harvest such testimonies and convert people who have had this vaccine to be immunization champions. And by the time they become champions, they're able to also talk to their peers, talk to their colleagues that this vaccine is safe and you do not have to be afraid. Next slide, please. Now, what are some of the innovations that we have implemented? One of them is iftar. As you all know, coincidentally, we are now in the month of Ramadan. So what we do is that we look for opportunities during Ramadan to get people in one location and to talk to them about the COVID-19 vaccine. And what do we do? Areas where we know there are hesitancy, we map them. And we look for the religious leaders in those locations. We look for the mosques where they preach. We engage the religious leader and we train him on how to address misconceptions and disinformation around any type of vaccine, whether oral polio vaccine or COVID-19 vaccine. So at the evening, before the break of fast, when they gather for prayers, after the normal prayers, the mosque leader or the imam will talk to the adherents who include healthcare workers, traders, barbers, all of them in the mosque. He will engage them and talk to them on the importance of the COVID-19 vaccine, the importance of other vaccines. He will use the opportunity to dispel some of the rumors, some of the misinformation or disinformation. And because he's a religious leader, they listen. And at the end of the preaching, the CGPP supports some token of small meals that they will use to go and break their fast. And for polio, we recorded 95% reduction in hesitancy. And we're using the same thing now that the Ramadan is going on. We're doing the same thing for the COVID-19. The other thing that we also do is optimize integrated in-between round activities. What this is simply saying is that in between the rounds, for instance, the polio rounds, we engage all the communities using some of the interventions I mentioned before, the compound meetings, the house-to-house, and we talk to them and we hear their concerns. So for healthcare workers, it is important, very, very important to listen to them. And when we listen to them, we talk to them in the language that they understand. And some of the interventions that were mentioned by the immediate past speaker, we use them. And that brings me to the issue of male peer educators. We realize that it is important to use your peers in order for you to listen. So for healthcare workers, we are training other healthcare workers to also engage them and talk to them. And what that does is that if you're listening to, if, for instance, a nurse is hesitant and a fellow nurse is telling her that, or telling him that, oh, I've had this vaccine and I think it is safe, I believe it's safe, they are more likely to listen when they are talking to their peers because they share the same experiences, they share the same problems. And then data peer review. Data is critical. And what we do is that we look at the immunization list, who has been vaccinated, who has not been vaccinated, where are the areas where we're seeing large percentage of healthcare workers or large percentage of people who are not aligning themselves to be vaccinated. And we regularly review and we regularly use that data for action. Interestingly, we also have what we call local entertainers or papalolo in our local parlance. These are local entertainers who are able to entertain the public, and as they are entertaining the public, they are passing the message about the importance of the vaccine. Importantly as well, we use the youths in the community as well as important agents of change. And that brings me to the last intervention, which is the youth engagement. You agree with me that in every community, the youth play a critical role in spreading information. And we use that doing using physical contact. We use that using Bluetooth devices where we send animated videos. These animated videos contain messages about the importance of the vaccine, messages about the safety of the vaccine, messages about the fact that these vaccines do not cause any side effects, messages about the fact that these vaccines are safe, messages about the fact that the sunlight does not kill the vaccine, messages about the fact that nobody is immune to the vaccine, messages about the fact that you need to use your face mask regularly, you need to wash your hands regularly, you need to use your hand sanitizer, you need to physically and socially distance. All of those messages are passed to the youth. And I can tell you that because youth in every community, they are the most diverse in terms of use of social media, use of smartphone, use of technology. They help us to disseminate these messages to as wide as possible. Next slide, please. Thank you very much.
Thank you. Excuse me. Thank you, Dr. Usman. That was a wonderful presentation. Being that we are already a couple minutes over, I wonder if we can just hear some final thoughts from each of the three presenters before concluding today's webinar. We would love to hear any final thoughts. Rupali, Deepa, Sam? Rupali?
Sure, I'm happy to go first. Thanks, Tyler. Thanks so much. It was great to hear from Deepa as well as Samuel. I think a key thing with regards to communication, I think my key thought from this would be that this dynamic is ever changing, which means our communication as well as our techniques need to be ever changing, which is going to be a challenge, right? I think we have our work cut out for us with regards to thinking about the ways in which we can promote vaccine confidence. But the great news is that there are a number of folks working in this space. And so I think it's really important to continue to leverage resources. There's a number of resources that have come out related to communication. And so I think that's one key thing that folks can hopefully rely upon. So it was great to be here. Thank you so much, everyone.
And thank you, Rupali. Deepa, final thoughts from you.
Yeah, thank you, Tyler. It was really great presenting with Rupali and Sam. I think Usman. I think we learned from each other, but also actually supported each other throughout the presentation, which is very interesting. So it gives a confidence that these things are coming out all across the world. But what I would say as a last parting message probably is that there is going to be uncertainties for a while. There is going to be lots of questions because this is not something which has been there for a long time. The scientists are still learning about how this virus is, changing every day, the variants and all. So it's going to be very important to be transparent and say, this is what the evidence tells us so far. And based on that, we'll have to make sure that we communicate transparently to the communities that we work with. This is what the evidence is telling us, but at the same time to make sure that they have more willingness to get vaccinated, because it does protect us from the disease as well as the severity. But also I think that it's very important to also say that vaccine is one thing among the other things. It's not going to be just by vaccinating people that it's a magic bullet. I already said that, but very important to reinforce that you have to continue doing these preventive behaviors. And last thing, the coordination at the country level. Let's all get together and support the Ministry of Health, who is the accountable entity to take this forward. And if we all bring together our resources and support the Ministry of Health, I'm sure that we'll get there. It's just a matter of time. Thank you.
Thank you, Deepa. Any final thoughts or words from you, Sam?
Yes, please. I think Rupali and Deepa have said a lot. I will just add that my little bit of icing on the cake, that it is critical that we continue to engage with critical stakeholders because the COVID-19 pandemic is here with us. It's not going to leave now. And so we must continue to engage, continue to change our information as the landscape emerges, and continue to inform people. Information is never too much, like have been said by the other presenters. People always bring up new things why they shouldn't take the vaccine. So as they're bringing in the new things, we also have to be nimble enough to bring new messages to address their concerns. Thank you.
Thank you, Sam. And we would like to give a sincere thanks to all of the presenters today. We know how busy a time this is for all of you, and we really, really appreciate you joining us to have this important conversation. So thank you to you all, and thank you to all of you who attended. Be sure to watch out for future Springboard events. All right, thank you, everyone.